Um, okay. My name is Nicole Billiard Marticelli. I'm a fourth year medical student here, and today I'll be talking about postpartum septic pelvic thrombophlebitis. And then this is just what I'm gonna go through. Um, so for our case presentation, and I do have this picture and another picture of the wound. So for our case presentation, we had a 34-year-old G3P2012 with a prior low transverse C-section and recent COVID infection without any other significant comorbidities, presented on post-op day 5 of a repeat C-section with sepsis secondary to a post-op cellulitis. So for her history on post-op day 4, she started having pain at the incision site, chills, low-grade fevers, diffuse abdominal tenderness, and intermittent sharp pains. And the cellulitis is shown here in the picture. She was on Keflex for 1 day by an outside provider, and she was hypotensive, tachypneic, and tachycardic when she presented. All her labs were pretty much within normal limits. She just had some mild anemia. Her white count was 8 at the time. Her EKG showed sinus tach. Her CT was negative for a PE. Chest X-ray showed some atelectasis and a small pleural effusion, but it wasn't very concerning. And then the CT abdomen and pelvis showed a lower pelvic fluid collection. She was started on IV Zosyn, Vanco, and Clinda, so we started her on broad antibiotics just to try to cover anything that could be going on. And she had some serous drainage of the incision with 8 centimeters tunneling. And then, so this is just like a snapshot of her course. So on day 5, her wound cultures came back her wound cultures came back, and she had ESBL, E. coli, Klebsiella, and E. faecalis, multi-drug resistant. So she was started on IV ertapenem and vancomycin, and the wound was fully dehisced at the time and drained. And we were changing her packing at 3 times a day. On day 7, we placed a wound vac, and then she was just switched to meropenem at that time. And she still didn't have any leukocytosis or any really abnormalities in her labs. On day 8, she was still febrile through this whole process, but the wound was healing well with granulation tissue. This picture that I put here was from, I think it was her 3 days after discharge, but it looked pretty good on day 8 as well. She had CT on day 8 as well of admission that showed a clearing of the fluid collection that we had previously seen and some pelvic ascites. So on day 9, she got an IR drain. And we also got blood cultures, peritoneal cultures of that drainage, which were negative later on. And she was started on PO Bactrim and Augmentin. And at that time, we were considering SPT as, a diagnosis if she were to remain febrile, even though our CT didn't show any ovarian vein thrombosis. She eventually remained afebrile for a couple of days. I think it was 48 hours. So she was discharged home to continue PO antibiotics for 7 days total, and continue her wound vac care. I think she's been doing well. She's been doing well. She has some leftover pain, but she's been doing well. All right. So for the presentation, so postpartum septic pelvic thrombophlebitis. Sorry. So we chose the topic because when we were, talking about her, we weren't sure how the diagnosis or the management of SPT was made. So we just wanted to dive a little bit further into that and, help share some information that might be helpful for future patients that might present with recurrent fevers that we can't figure out where it's coming from, which was what happened to her. So for SPT, it was described by von Recklinghausen in the 1800s as a thrombosis of one or both ovarian veins. It is known to be a rare but potentially life-threatening condition that occurs in 1 out of 2,000 deliveries, being 1 in 9,000 vaginal deliveries and 1 in 800 cesarean deliveries. So much more common in cesarean deliveries. There's a few reports of SPT not associated with pregnancy, maybe associated with other gynecological procedures and malignancies, but they're very few to have an incidence rate. The mortality is 18 per million pregnancy, and then 2% of people who develop SPT pass away from systemic spread of the infection. And a little bit of the pathophysiology of pelvic vein thrombosis. So it's usually thought to be, the varicose triad. So we have hypercoagulable state in pregnancy, stasis from the reduction of blood flow in the dilated urine and ovarian vessels in the postpartum period, and an injury to the intima from various reasons. Spreading uterine infection can be one, bacteremia can be another, endotoxins and trauma of delivery and surgery is another pretty big one. So there's a few different types of pelvic vein thrombosis. You can have ovarian vein thrombophlebitis, deep pelvic vein thrombosis, and septic pelvic vein thrombosis or thrombophlebitis. And those can also be related to PAD, pelvic surgery, and malignancy, like I said before, with a very low incidence. And in ovarian vein thrombosis, 90% are unilateral and right-sided. And it has been proposed that it's because of the retrograde flow in the left ovarian vein that prevents, ascending infection on that side. So that's why it's usually seen on the right side. And then specifically for septic pelvic vein thrombophlebitis, it can involve ovarian veins or smaller pelvic veins. So we're going to talk about this later, but sometimes it's not really seen on the CT if it's, a smaller pelvic vein that is involved. Some of the risk factors, I touched a little bit on this, but I think the new ones here would be an induced abortion, uterine fibroids, underlying malignancy, and hormonal stimulation. Of note, septic ovarian vein thrombophlebitis with positive blood cultures rarely follow a vaginal delivery in the absence of risk factors being instrumentation, uterine manipulation, endometritis, or infection of the episiotomy, if there is one. The diagnostic approach, so usually this, SPT will present as a spiking pattern of fevers. Our patient had fevers every night, but she was usually okay during the day. So that kind of fit the picture. So these fevers fail to respond to antibiotics, and they can happen within 5 days of a procedure or can be delayed up to 3 weeks after the procedure. And 20% of patients have this prolonged fever regardless of antibiotic therapy. Other possible symptoms could be some pain, some tender abdominal mass described as rope-like or sausage-shaped, and it could also cause paralytic ileus. In the 60s and 70s, they described like a third of patients had evidence of PE. It's been less reported recently, and about 2 to 3% of cases. And this might have to do with, us being able to diagnose it earlier and treat it earlier as well, or manage it earlier. And then of course you have to exclude, if this is the picture that your patient has, you have to exclude other causes of postpartum fever, such as like endometritis, pelvic abscess, wound infections, mastitis, UTIs, and even a PE. So continuing the diagnostic approach, so CT and MRI have been shown to be superior to ultrasound for ovarian vein thrombosis. CT has 100% sensitivity and 92% specificity, and MRI has 99% sensitivity and 100% specificity. So those tests are pretty good for the ovarian vein thrombosis. I couldn't find a lot of data on like the smaller vessels, like I mentioned, for just SPT. There doesn't seem to be a lot of data on that. So here I have a little bit of the, CT and MRI criteria for diagnosing those things. So you'd see on the CT, you'd see a low density lumen within the vessel wall. And then with the MRI, the thrombosed vessel would be brighter than you'd expect. And then with the MRI, you can also see a better visualization of like the resolution of the edema and the changes that happen. And lab tests are really non-specific. You could have some leukocytosis, but again, not always. Our patient also didn't have it. And then for blood cultures, less than 3% of cases are positive. And the bugs you should consider E. coli, anaerobes, staph, and strep. So these are just some pictures of a CT showing a right OVT. So you can see it here on this picture over here. I don't know if you can see my cursor, but you can see the arrow signs as well. Okay, cool. Oh, I guess I didn't put an MRI picture, but I forgot to add that one in. Okay, so for the management, in the 60s, surgery was the go-to for this. And then more recently in the 70s, Brown and Associates, described this this management option here with heparin for about 3 weeks, antibiotics, and then maybe surgery depending on the case, and then bed rest, avoiding OCPs for future pregnancies. And they described the good prognosis for future pregnancies. And honestly, our management hasn't changed that much since. And there's a huge lack of consensus on what to do regarding anticoagulation and antibiotics. So this is a chart that I kind of made, and I can walk us through really quickly. So for OVT specifically, if it's not in the postpartum period, you should evaluate for thrombophilia, and the therapeutic management of that remains unclear. If it is in the postpartum period, it's indicated to start antibiotics, and then for at least 72 hours, and then continue it for up to 72 hours of a patient not having fever, or up to 7 days, depending on the case. Again, there's not much agreement on that. And then you could do heparin or low molecular weight heparin for 7 to 10 days. Or if you have a right ovarian thrombus with extension into renal veins or IVC, you should do warfarin for 3 to 6 months. And then you can consider a follow-up CT to determine the treatment endpoint. Again, people don't, the sources don't really agree on what's the best course in that sense. For small thrombosed veins, it is recommended to use alongside antibiotics for 72 hours and up to 7 days. You could do enoxaparin 1 mg per kg for 1 to 2 weeks, or unfractionated heparin for at least 7 to 10 days after fever resolution. So a few notes here. So for postpartum SPT, the addition of heparin has not been shown to reduce fever duration, but it is used for PE prophylaxis, or to lower the incidence of PEs. For malignancy associated thrombus, you may not require anticoagulation because those usually resolve on their own. And for surgical and percutaneous interventions are not usually indicated. And then I just have the heparin dosage down below. So for the antibiotic choice, it's going to depend on your culture and sensitivities. They recommend the shortest possible course. And down here, I have some of the types of antibiotics that were recommended. There is some controversy, like I said, in the use of anticoagulation to prevent PE, but it is not very much used in the post-surgical or malignancy cases outside of the postpartum period. And then the IVC filter or hysterectomy with ligature of IVC and ovarian veins is done only if there's a high risk of PE or recurrent PEs with SPT. some of the complications. So you can have a PE of a thrombus or septic emboli, sepsis, migration and spread of the thrombus to other areas. You could have an ovarian abscess, obstruction or infarction of the ovary. The mortality, like I said, is about 2%, and the recurrence is possible, but it's very rare, and there aren't a lot of studies on that as well. And no prophylaxis is recommended for future pregnancies for that reason. And then something I just wanted to look up a little bit was, inherited thrombophilic states relating to postpartum OVT or postpartum SPT. And there isn't a lot of data really. There were 2 case reports of APLS complicated by OVT, but it was not in the postpartum period. And they treated it with IV heparin. And they kept, and then long-term fluindapyr with an INR of 3. And it seemed to be effective to prevent recurrence, but those people were on that treatment for like over 4 years after the initial presentation. There's one case report of a patient who possibly has antiphospholipid syndrome and developed an SPT. But again, they just used the regular recommendations that I just talked about. And they didn't have any much on the follow-up or like what extra prophylaxis this patient was on. So it was really just a report saying that it has happened on someone that has APLA, but not much data really came from it in terms of like future management and prophylaxis for future pregnancies. And that was about it. Do we have any questions?
Well, that was a great overview. Thank you so much for doing this.
Yeah, of course. Thank you.
Yeah. I know for the sake of the fellows teaching, we had a case where actually, so basically if you have to fully treat these patients or at least like prophylactically manage them. So there was a very nice review that Hannah Anastasio, when she was a fellow here, that she pulled up and really changed what we do. So I wish I saved it, but I'll dig my brain to see what was it, but it was very clinically applicable. Any other questions? When you called?
I just wanted to tell you that we reviewed this topic because when she was so sick and having fevers every day and we're getting desperate because she was sort of septic, and we entertained the idea that it could be a pelvic thrombosis. Well, I wanted to know, like, how specific is the test? Is the CT scan enough? Do we need to do another test? Do they need to do an angiogram or something, or just start the heparin? So we made a empirical plan with Dr. Rosenblum about if she spikes 101 or more, we were going to start the anticoagulation, but she then started getting better. So we didn't have to do it, but I still have a lot of questions. So thank you so much, Nicole, for the review.
We always learn from our patients, basically. This is the message. They inspire us. Great. So for the sake of time, we are going to start our abstracts. And I think, Katie, you're the first one. If we can share.
Yeah, I'll share. I have it pulled up.
Yeah, and we have a large number of abstracts, so we're going to try to be as efficient as we can. Go ahead, Katie.
Can everyone see my screen? I'm going to make it small so folks can read it.
Yes.
All right, I'll give you guys like 2 minutes.
Just a question. Our other student also had that topic, so I wonder if there will be somewhere in between or at the end. So
I think we should do it.
Yeah, I know.
Okay.
Probably at the end because we have residents. What?
No, who would I think the student, if you have another student presentation, you said?
yes.
That should go first. Yeah.
Okay, go.
Cool. Thanks.
Thank you so much.
Sorry about that.
Okay. Let me just pull up. Sorry, we're having some microphone issues over here. Okay. Okay. So I'm going to be talking about the use of subcutaneous extended release buprenorphine, also known as Sublocade, in pregnancy. So we had a patient on our service recently. She's a 23-year-old G1P0. She presented at 28 weeks and 3 days. She presented to the ED initially for benzodiazepine taper after a relapse of benzodiazepine use. She, during the 1.5 weeks preceding admission, had been using Klonopin that was prescribed to her for her panic disorder, as well as Xanax that she acquired off the street. And she reported using a total of approximately 60 milligrams of benzodiazepines a day. In digging into her history a little bit more, she also endorsed a more remote history of opioid use. She said that she hadn't used anything for the last 2 years, had previously been on Subutex, but had stopped taking that 7 months prior and had not taken anything for her opioid use disorder in the interim. She also had a medical history of ADHD, PTSD, as well as the aforementioned panic disorder, as well as previously treated hepatitis C. So when we got her urine drug screen, most of the things that came back positive were not so unexpected, but you can imagine that we were a little bit surprised when it came back positive for buprenorphine, when she had told us that she hadn't used it for 7 months. So after talking to her a little bit more, we found out that she was actually getting injections of Sublocade, which is an extended release, basically depot form of Subutex. She had been getting this from for I think a 7-month period. So I don't know about everyone else on this Zoom, but I had never heard of Sublocade. I didn't even know that there was an extended release injectable form of Subutex. So I thought it'd be interesting to talk a little bit about, what we know about this option for medication, as well as what, if anything, we know about its use in pregnancy. So Sublocade was approved by the FDA for use of treatment of opioid use disorder in 2017. It's administered as a monthly subcutaneous injection every 28 days. Patients are started with a 300 milligram loading dose. They get that for the first 2 months, and then they transition to 100 milligrams every 28 days. And it's an abdominal subcutaneous injection. This is appropriate to offer for patients who have been stable on 8 to 24 milligrams of Subutex a day. And patients have to be stabilized on the Subutex or Suboxone for at least 7 days prior to initiation to avoid precipitous withdrawal. So we already know, that buprenorphine is safe in pregnancy, thanks to the landmark mother study that was published in the New England Journal in 2010, which deemed buprenorphine as acceptable treatment for opioid dependence in pregnancy, as well as actually proved that it may have some benefits for patients. It showed that, neonates born to mothers exposed to buprenorphine compared to methadone had shorter durations of treatment for neonatal abstinence syndrome, as well as lower morphine requirements and shorter hospital stays. So then looking at what's been looked at in terms of this extended release form in pregnancy. So there were animal studies that were done by the pharmaceutical company in their trials. In rats, they found that the injection, when administered before mating and during organogenesis, led to increased rates of post-implantation pregnancy loss, higher rates of resorption, and increased low birth weight. They also found dose-related increases in skeletal malformations, especially of the skull, as well as visceral malformations. So the first 3 bullet points here, the implantation losses, the resorptions, and the decreased weight, were also seen with equivalent doses of just the delivery system of the buprenorphine without actually adding buprenorphine. So it's thought that this is actually maybe more associated with the vehicle of the injection and not the buprenorphine itself. On the other hand, the skeletal malformations are thought to at least be due partially to the buprenorphine alone. It's notable that in rats, these effects were observed at around 38 times the maximum recommended human dose. And so they deemed the no observed adverse effect level at about 15 times the maximum recommended human dose. They also did a study in rabbits that found similar increased rates of similar defects at slightly lower doses. So these were anywhere from 7 to 15 times the maximum recommended human dose, again, finding that the increased post-implantation loss, resorption, and decreased fetal weight were also seen with equivalent amounts of just the delivery system. So what is it with this delivery system that is causing these defects? So Atrogel is the name of the vehicle of this injection. It's a 50-50 mixture of peptide, poly-D-L-lactide coglycolide, as well as a solvent, N-methyl-2-pyrrolidone, or NMP. So based on molecular weight, poly-D-L-lactide coglycolide is very unlikely to cross the human placenta. Its molecular weight is like upwards of 60,000, versus NMP has a very low molecular weight of around 99 and very likely would cross the placenta. NMP is also well known in several other industries. It's used frequently in the manufacture of plastics, surface coatings, pesticides, and is also used in like paint stripping processes. It's used to remove graffiti in the electric industry, which I thought was a fun fact. So studies that have been done on NMP historically were done mostly for the purposes of evaluating their effects on development for people who had occupational exposure. It was not necessarily like in the evaluation of this injectable buprenorphine medication. So keeping that in mind, these studies were done where they tested rats with inhalation and oral administration of NMP, typically during organogenesis, at doses that are close to equivalent or higher than that in this injection. And they did find, again, increased rates of pre-implantation losses, delayed ossification, reduced fetal body weight, as well as skeletal malformations and cardiovascular malformations as well. In rabbits, notably, they did not find any adverse effects reported at an oral dose that was equivalent to the maximum daily dose recommended in humans by body surface area. So moving on from animals, the next obvious question is, what data do we have on its use in humans in pregnancy? So there are only 2 published cases in existence that I could find on pregnant patients receiving Sublocade. The first patient received their first dose about 3 months prior to their LMP, and then followed the recommended dosing regimen and had 6 100 milligram doses after their initial 2 loading doses, with the final dose given at around 17 weeks, 4 days of gestation. The patient learned the following week that she was pregnant, chose to stop the injections, and remained opioid-free throughout delivery. The second patient had a total of 6 injections, again, the 2 loading doses followed by 4 months of 100 milligram doses, with the final injection being given at the time of her LMP. Also declined buprenorphine replacement in pregnancy and remained opioid-free through delivery. So for each patient, they then looked at their urine levels of buprenorphine as well as the metabolite norbuprenorphine through delivery, and they looked at maternal symptoms as well as neonatal outcomes. So the outcomes here are actually pretty amazing. Both patients had buprenorphine detectable in their urine through delivery, so months after stopping the injections. The only side effect that either of them had were palpable nodules at the injection sites, which did eventually dissipate. Both had uncomplicated term vaginal deliveries. Both required only acetaminophen and ibuprofen for postpartum pain management, and neither of them had any symptoms of opioid withdrawal through their delivery. Both newborns had normal APGAR scores at birth, had no birth anomalies, did not develop neonatal abstinence syndrome at all, and at pediatric follow-up at various lengths of time had normal exams and were meeting normal pediatric milestones. So I guess with that animal data and with those 2 human case reports, altogether, what do we know about Sublocade use in pregnancy? So the FDA has deemed Sublocade category C in pregnancy. meaning again that animal studies show adverse effects, but that the benefits may outweigh the risk in certain human cases. And the correlation of these adverse effects in animal studies is always uncertain with expectations of what would happen in humans. So in other words, use is controversial for now. The case reports that we just discussed are very promising, but again, there's only 2 of them. So we need more data before we can definitively say whether or not this is safe for use in pregnancy. However, keeping in mind, as we know, like opioid use disorder is a growing issue, especially in this country. And this could be a very helpful treatment option for many patients if it is shown to be safe. Some of the benefits that it would offer would be the possibility of improved adherence to opioid replacement therapy. Patients wouldn't have to go to a methadone clinic every day or even take a pill every day. They would get an injection once a month. Once the medication reaches steady state, just after about 4 to 6 months of use, it then, even if you were to stop at that point, remains at steady state for another 2 to 5 months on average. So there really is kind of extra benefits, even if they do stop using it after a while. There's a lower risk of diversion. The injections have to be administered at like certified specialty pharmacies with the special program. And because of the extended release nature of Sublocade, withdrawal symptoms are expected to possibly be more mild after cessation of use. So going back to our patient, she received 7 total doses of Sublocade, with the last one given at in her 5th week of gestation. No buprenorphine was taken thereafter. She had no symptoms of opioid withdrawal prior to the admission. Records of her anatomy scan at 20 weeks and 2 days did not show any anatomic anomalies. And she had a fetal echo done at 22 weeks as well that showed no abnormalities. On hospital day 3, she did begin exhibiting signs of opioid withdrawal based on COWS scoring, and did choose to start methadone maintenance therapy. She was successfully tapered off of benzodiazepines. It's worth noting that she did not actually get the 2 initial 300 milligram loading doses. She only got 1 300 milligram loading dose and then was transitioned to 100 milligrams. So again, not enough data, but that might possibly play a role into her experiencing withdrawal during pregnancy. Just an interesting case to look at. So we had discussed whether or not she would be a good candidate for an additional case report. I think ultimately there are maybe too many confounding variables in her case, namely the benzodiazepine use and the taper and symptoms of withdrawal from benzodiazepines, crossing over with opioid withdrawal symptoms quite a bit, as well as the her choice to begin methadone management. So I think it would be very difficult to assess what role the Sublocade is playing in her symptoms in her pregnancy course, although it is interesting that she did start experiencing withdrawal, whereas neither of the patients in either of the case reports that we discussed did. That's all I have. Just thought this was interesting.
Quick question, did you find a pregnancy reporting system that usually it is associated with the pharmaceutical company?
Yeah, so they do have a phone number that. Sorry.
Answer to the comment.
Oh, there is a phone number listed on the pharmaceutical company's website for reporting pregnancy. I did not have a chance to look into like how many reports they'd had. I didn't find any other published reports other than the 2 that I discussed. But the pharmaceutical company did have, like, in their the long document with all of the like specifics of the medication. There is a pretty lengthy section about use in pregnancy. It does not anywhere specifically say like not recommended for use in pregnancy. It gives all of the same warnings that something like methadone or Subutex would have, with the risk of neonatal withdrawal syndrome. But it also it talks about the animal studies that I referenced before.
Thank you, Mikal. Outstanding presentation, outstanding care of the patient too.
Do you want, is it okay if I share the abstracts now? We'll start. Sounds good. Thanks for letting me go first. I'm gonna jump off at 11 to do some intern school. Can everyone see? Yeah. I'll give you guys a couple of minutes to read. And then I can show the tables. I want to show what the initial step of the CMQCC sepsis screen looks like. And then this table 2 is like some of the clinical characteristics that I outlined. The question that I have is like, these are all not, there's no difference. So if it would be better if I, one, like I don't need another table, or if it's better if I highlight of those that screen positive, like what percentage meet an individual criteria. And this is like very preliminary data that's been collected
Yeah.
for what my thesis will hopefully be on. But that was my main clinical question, is if you think that that table 2 is best as a table or none at all, or if we should highlight like the specific criteria, what percentage was met.
Katie, you already know my opinion, probably.
Yeah, I think you think it's better as like of those who screen positive with criteria.
Yeah, I think table 1 is certainly important so that people know what CMQCC is, correct?
Right, and like what the parameters are, for sure.
Yeah. And then in your results, what was exactly? Because some people have more a visual memory for the results. And if you put a sentence, you know, the maternal demographic, you know, these were not changed, and that's it between the cases and controls, you know?
Yeah.
What do the fellows think? Maybe go to the table, maybe show them that sentence, bold that sentence that you're asking about if you should create a table for it. Or not.
Yeah, what I would basically do is just make a table like 2 out of 4 criteria were met, 3 out of 4, it would be like very short, very small.
And what were these criteria too?
Well, the criteria are listed in table 1.
No, I know, but those that had only 2, what was it? It was fever, probably, and heart rate, let's say, you know?
Yeah, so I didn't, like, I don't have, oh, it's fever and heart, like, I didn't break it down like, oh, I know what each individual did, but I don't think it's super relevant to know, is it fever and heart rate that are the 2 criteria for each individual?
Yeah, oh yeah, yeah, but I think for the paper, they're gonna want to know, right? If they have
Oh,
two
yeah, I
criteria.
have that. I just don't think like, I think it's just more helpful to know, was it 2 criteria that they met or 3?
Can you do table 1 as like a figure? Because I think you can include 1 figure in 1 table.
I could do this as a figure.
Oh yeah,
How would I just like a figure, like, just like make it more
Like, you just
graphical,
upload it.
do you mean?
Yeah, just like take away like table 1 and just put like criteria for sepsis rate and just put it as a figure instead of as a table.
Yeah, that's a great idea, just like semantics.
Yeah.
Yeah, Katie, you can just screenshot it and then upload it
Yeah,
that way.
just like
Yeah, that's a great idea. I'll make it pretty and say it's a figure. Perfect. And then do you guys have a preference? Would you rather see like this, or do you think it's more helpful to say what percentage of the criteria were met?
well, is the goal to show the difference between the 2 groups, or just to show that only 68% like met criteria?
I mean, I think the goal, I think the better goal is to see like how many met each criteria. I think this is just like these outcomes aren't, the groups are equal, and eventually the point will be like what the like end outcomes are. I just like haven't looked at it yet. So I think what's more relevant is like what percentage of people screen positive and what that looks like.
Yeah, I think that's fine.
All right, so I'll
I think you
change it.
just put a sentence in there saying that there's no, where you already have it, there's no difference between the two groups.
Yeah, so I have that. So I think that's fine. And then I can make kind of these two sentences into like a table representation.
And I loved how you said, maximum temperature, in labor did not differ, because people think, oh, the temperature is like 103, 104, Basically,
Yeah.
there's really no difference in the septic, in the screen positive criteria versus negative with this.
No.
Did you include neonatal outcome, admissions to the ICU?
Yeah, so I am
treatment or
going to, I
evaluations?
didn't
Okay.
for this like initial review. I just haven't looked at that yet.
Needs help.
What was that?
Just a couple of, I think you need to define III once before you start saying III.
Yeah, that's where I get into it. III is like the longest sentence, and it's really annoying to me. I don't know, like.
I think we can skip it. This audience knows what III means. Yes, Dr. Baxter.
Katie, excellent. I would suggest defining the term and taking off. I don't see it on the screen now, but I think it was like the second sentence.
Yeah.
You give some kind of background information that's like, hey, this is important. Like anyone reading the abstract would know it's important. So it's kind of a sentence that may not be as useful as defining III.
Yeah, I mean, I would argue that anyone reading this abstract should know what III is also.
Yeah, but anything, but if it's not, like even if you use the term SAB because it's an abbreviation or something, even that, you should have some way to put it one time at the beginning.
So I would just take out, I'm sharing now, just take out this first sentence and then just define III.
Yeah, I would substitute a triple, define it, yes.
Yeah, all those words that no one knows, and we just call it III.
I might also change your title to be a little bit more descriptive in case people are just.
Yeah. Okay.
Shall we add CMQCC to the title or no?
I can add it.
Yeah.
I'm asking that.
I would feel like using the CMQCC sepsis screen.
Yeah, that's a great idea, because people will be like, oh yeah, I've heard of that.
Yeah.
And
then just
it's going to.
What was that?
I
Sorry.
think you have to write however, but you just put how.
Sorry, I couldn't hear you. What did you say?
Oh, I said in your conclusion, I think you meant to say like however, but you just wrote how.
Oh, thank you. Thank you. How. Or how, I think I did meant to say how, or I'm gonna say, I'll find a better word than how, because I want to be like.
Yeah. I had the same comment. I've been thinking about that since last night.
Yeah. I'll make this stronger.
Okay.
And I don't have enough words to like fully define all the parameters of III, so I'm just gonna put like the full words of III. Thank you, guys.
Thank you, Katie. Okay. The next presenter is going to be Anjali Patel. Anjali is our own fourth-year medical student. She'll be a sub-I with us next month, Anjali, on HighESC. And Anjali is presenting for Kavya. Kavya is a second-year resident at University of Illinois at Chicago. And it's really a case report. What we really need help is making sure that the abstract flows well. It is a case report of a genetic disorder. And basically, every year I submit a case report. I get surprised that it gets accepted. So I don't want to jinx it this year. So we will see. but you know, it's all worth it because very limited data is published on things that we diagnose here. So yeah, the flow, hopefully you let us know. And any edits, of course, to make it look stronger. Does the story seem okay to you or no?
Sorry, I just want to clarify, because this is probably just me not knowing, but I didn't think SMFM accepted case reports.
They, for some reason, they've been accepting with me. Almost every year I have a case report.
Nice.
But I agree with you, it is unusual. It started a few years ago when I started to send my genetic stuff, so.
Do you do any amnio or any testing for fetus?
Oh, she declined,
Oh, let's write it down, decline amnio.
yeah.
Is it, a question I have, is it necessary to include an amnio if the partner tested negative?
Not, you know, not necessary. But you know, for MFMs, they always ask, you know, did you offer prenatal diagnosis? So I think if we have space, I'll check on the word character. We can say decline diagnostic testing.
You're going to have to get rid of the words Thomas Jefferson University in the study design so that it'll be anonymous for reviewers.
Oh yeah, case support. Oh yeah, you're right. Thank you.
And I would just say a case of a patient, just take out the word report so it doesn't flag them being like, we don't accept case reports.
Oh yeah, yeah. Case of a patient with CSPD managed. How about managed? I don't want the treated. Should I put genetics there or no?
Yes, genetics.
Okay.
Can you just say a patient? No need to say case of a patient, but just a patient with.
Okay, primary carnitine deficiency, study design. How about we say management at genetics and high risk obstetrical care? Does that sound good?
Yeah.
Better. Okay, thanks. Let me know if the results flow and the conclusion.
Yeah, I would take out, she underwent preterm premature rupture of membranes. I would just say like preterm premature rupture of membranes occurred at 30 weeks one day.
Okay,
Because she didn't like undergo, it's not a procedure gender one.
okay. Shall we take, she subsequently conceived by IVF or no? Because it's not really relevant, you know?
Any pre-implantation genetics?
No,
Okay.
Did she do the carrier screening because she was getting IVF?
yes. Maybe we should do that then. Actually, we should start it like a story. Yes. Genetic carrier screening. Yes, as part of IVF workup.
Is there any table or figure associated with this? If not, you could probably make something looking at the trend in the carnitine levels.
Oh, yeah, that's interesting. Yeah, we do have all the carnitine levels for her. At which gestational age too?
Yeah.
Yeah, you can make like a timeline with carnitine levels mapped out.
Yeah, I think that would be nice. And those, yeah. And we're gonna need that for the paper too, Anjali,
Yeah, sounds good.
with the changes in her dosing also.
Mhm.
Believe it or not, the patient was a pharmacist too. And then the conclusion is very interesting. Would you say it's a successful pregnancy or no? She had preterm premature rupture of the membranes and preterm delivery.
Yeah, I wouldn't say a successful pregnancy. And I don't know if you need it's more like a discussion, the part that you write. There are 2 cases of untreated maternal CDSP supporting full-term delivery complicated by oligo and neonatal epilepsy.
Yeah.
I don't know,
Yeah.
is the conclusion of that.
I just want them to know that so far we've only found 2 cases of this disorder. Shall I put that in the objective then, or just take it out together? Shall we say there are only 2 other cases of maternal CSPD reported in pregnancy and further research is necessary?
Maybe in the conclusions.
Yeah. So Amanda will join the last 2 sentences. There are 2 there are only 2 cases of untreated maternal carnitine deficiency in pregnancy. I'm not going to talk about the outcomes, and further research is necessary to determine basically the full effect of carnitine deficiency in pregnancy. What do you think? I think that's a stronger statement.
I think I'd include this in conclusions. Sometimes people start reading the abstracts from conclusions and then decide if it's reading the whole thing.
Yeah. So what do you think? So Dr. Oman, do you think we should take it all together, the last 2 sentences? I just want them to know that they have been very limited. Certainly the oligohydramnios and the epilepsy have to be out.
People say this is one of the 3 published cases.
Oh, okay. Perfect. This is one out of 3 published cases of maternal. Perfect. I love it like that.
I might be careful saying published because that's a rejection from SMFM as if your data has already been published.
Yeah, we have not published it yet, so fine.
Cases.
So one of the 3 documented cases or one of the 3 cases identified?
There are only 2 documented cases in the literature.
Sarah, I didn't hear you.
Maybe just say that there are just 2 documented cases in the literature.
Okay.
Yeah, only
That's
2 cases were
body.
identified.
In the literature. Okay. How about the last statement? Shall I keep it or no?
This is a very tiny comment about semantics, but I may change it to say our patient with CDSP to use person first language.
Okay, sounds good.
Thanks, Keely.
I will comment on the successful word. Successful, it depends on what you're looking at. Are the other cases untreated fetal demise or neonatal demise, meaning it was successful because the baby went home? I still call it a success.
Maybe just F-born.
I don't know what happened if you don't treat appropriately.
Yeah, it could be that she had other reason for sure, probably like preterm premature, not the carnitine deficiency. So what did you suggest, Sarah, to replace successful with?
I would just say live born instead of successful.
Okay.
Yeah.
I think this way we will be describing it exactly as it is. For MFMs, 30 weeks, oh my God, this is great, right? So, but still it's Peter. Okay, any other comments, or we think we're done? Do you think my objective was too long? I had to tell them what this gene is and what's the manifestation of this disease. This is not like preeclampsia or diabetes.
I think that your word count is good. I will keep it.
Keep it. Okay, great. Very good. Okay. It is 10:55. I think we're good. Can we move to the other abstract now? I think Sarah is presenting. Thank you so much, Anjali.
Thanks, everyone.
Jen or Sarah is presenting. Jen, if you're ready, we can hear you.
Yeah, I can go. Hold on. Give me 2 minutes. Let me pull it up. I have 2. One of them is an update from last week. It's the paper I was doing with Rodney and Kavisha. Let me share my screen. And the other one still needs quite a bit of work.
Mhm.
Okay. So this was the same paper I presented last week. Last week we had comments that we should look at it by gestational age, like 34 to 35, 35 to 36, and 36 to 37. We ran that analysis and we still found that the findings were the same. So I added a sentence about that here. We're right at the limit. We're at 2099 characters. But my question, so not much in the body has really changed, but I can leave it up if people want to read it.
But can I know your question so that I can focus on it though, Jen?
So our question was, we wanted to know if antenatal late preterm steroids was associated with a lower rate of respiratory complications in neonates born to late preterm patients with pre-gestational diabetes, because usually these patients are excluded from, like they were excluded from the ALPS trial.
Was there a difference in gestational age in the?
No. So I added that here, and then once everyone's done with this, I can show you.
No, I'm
guys.
saying it just in between the groups, was there a difference in gestational age?
No.
Okay.
Jen, I think this conclusion is greatly improved and I love it. Thanks.
Thank you. My question was for the table. So we did the first table as our demographics.
Yep.
And then our second table initially was our primary and secondary outcome. And then we did it again, controlling for gestational hypertension, chronic hypertension, and LGA, since that was found to be significant. But we also made another table as an alternative, and I wanted to see what people's thoughts were, where we did it by gestational age. So like 34 to 35, 35 to 36.
I like that table a lot.
This one, right?
Yeah.
Okay, that's what we thought too, but I wanted to just hear other people's thoughts.
Yeah, I like it too. My only issue is this is going to shrink probably by 70% or 40% to fit on that tiny box quarter of a page. How can people see these numbers, Jen?
The other thing we can do is we can take some things out. We can take out APGARs.
It's the width, honey, not the height that matters.
Jen, I'd make a suggestion, taking your left column called outcome. That's the one that's consistently 3 lines. And if you lengthen that out to make it on 1 line, you can actually, it'll shrink this into so that everything is 1 line each.
No, the problem is the width, because that's what's limited. The way they present it, the way it's published, it's kind of in column form.
Yeah, so you can go down.
So you can go down,
across.
but not across.
Yeah.
Exactly.
Yep.
The other thing is use a PDF and turn it like a figure. And so make it long and thin, but then they can make it go down there. That's, you know, another trick to work around that.
Okay.
And I would take out surfactant use. I think that's, you know, that's just not usually a high. People aren't usually wondering like, oh, did they get surfactant or not? But the other ones I think are relevant regarding the assisted ventilation.
Okay, cool. I will let Kavisha has an interview today, so she couldn't come, and Rodney's on vacation, but I will let them both know that everyone agrees with this table.
And I think, yeah, removing the all included birth. Other way is if you need to make it that wide, when you upload it into the website, put it upside down, like sideways. So it will get published sideways.
Oh, okay.
That's an
Like
option.
turn it
I
to
don't know.
landscape.
Yeah, because it needs, remember it's 3 inches wide.
Okay. All right, thank you. And then I'll share my other one. And that's more in the form of what we had talked about last week, like a lot of empty tables, and I still need to do the stats for this. But this was using so this is a project I did with Ashika and Dr. Bolig. She's one of the med students. We use this large multi-center REDCap database looking at ultrasound indicated cerclage and antibiotic use at the time of placement to see if latency was prolonged. So this is just our basics right now. I'm still working on the stats, but I've done some of the basic stats for characteristics, and then I can show you my plan for the primary and secondary outcome table. So I looked at race, BMI, prior preterm birth, tobacco use, if they had a prior Weber cone, substance use, methadone, whether they got Indocin perioperatively, and then suture material. I still have to run progesterone use, and we were going to look at vaginal and 17-OHP to see if there was a difference. Our primary outcome was gestational latency. And then I was also going to look at preterm birth, early preterm birth, PPROM. I was not sure if we need to include C-section or vaginal delivery. I don't really think it matters. And then exclude these. Okay. And then APGARs and NICU admission.
And then similarly for table 1, I think you can cut out some, just include the key demographic things. Like for example, you can do race, Black versus non, rather than list all of it out.
Okay.
Actually, I guess there's not that much to cut out.
Yeah, because I feel like the rest of these are like,
yeah, they're all
things that people want to know.
Yeah, I think suture is important.
The question, why they have an ultrasound? Ultrasound indicators or class for me means that they all had history of preterm delivery.
Right. That was also my question, but this was multi-center, and some centers are calling it an ultrasound indicated cerclage if the cervix is like 10 millimeters, and they still offer them a cerclage.
For without a prior preterm birth is what she's
right.
And the other thing is, if they had recurrent second trimester loss, so it doesn't come up as a prior preterm birth, because it's technically over 20 weeks, but it was second trimester loss, that would be, and so they're getting surveillance for that.
Okay. If you want to enter mode of delivery, enter just one, because one excludes the other one. So either you had C-section or vaginal, so you don't need both. And I would like to stratify, I would like to know how the patients with prior preterm delivery do. Because they may have different outcomes depending on the indication of the ultrasound. And also I'll be interested to know how did they perform in different cervical lengths. Maybe you need antibiotic for the less than 10, but not for 10 to 25.
Oh, Jen, do we have cervical length in there?
What was that?
Do we have, did I give you cervical, did we pull cervical length?
We did. Oh, I have to add it. I should add it here.
Yeah, you should
probably put it here.
Pre-operative cervical length. I think we did, like, just kind of without doing any data cleanup, we did a multivariate analysis, and I don't think, I can't remember now. Maybe we didn't do it.
Do you have the post cervical length or the height of the stitch?
We do. Should we add that too?
Because that also impacts on the outcome. As per Dr. Bergela's paper, if you place the stitch above 18 millimeters, you have a much better outcome. Those are the big confounder.
Okay, so I can include that
You
here
got
too.
the same antibiotics, Jen?
No, so for the a poster, we were gonna do yes, no. But some people, we were gonna eventually split it up by type of antibiotics. So most people got like a macrolide, or sorry, like a penicillin-based antibiotic, so either Ansef or penicillin. And then the second biggest group was a macrolide, so like a Zithro, Chlorithro. They even gave some metronidazole, which I thought was interesting.
I would put, if you have room, just
Mhm.
in the results, I would just say this percent received this antibiotic, this percent received this, just so people, like,
Okay.
people would probably wonder, you know, what were the antibiotics.
People are also going to ask you about vaginal infections, BB, GC chlamydia.
We have that also. I can add that to our demographics, or do you want me to put it in our results? Because it was actually, it was just, I asked if they had any infections during the pregnancy, actually.
I think it's, the problem with that is I don't know how well documented that type of finding is. And so
Yeah.
I hesitate to include it if it's not prospectively collected.
Okay.
I know, if you can enter that data into the body of the abstract, that'll be great. If you have room, like the table speaks by itself. You don't have to write everything, things that are already on the table, but things that are not in the table, I would like to know, like BB or any presence or not collected. So at least you check that box and the reviewer will say, okay, you talk about it.
Okay.
Dr.
And-
Baxter, yeah, was having his hand lifted.
Yeah, following up on the comment about prior preterm birth that I think
Mhm.
Amanda noted. I recognize that you're calling this ultrasound indicated cerclage and acknowledging that ultrasound indicated cerclage is probably better named prior preterm birth and short cervix on ultrasound indicated cerclage. That's like the long name for it. And
Mhm.
I apologize that we didn't better name that. But recognize that if you're going into this looking for ultrasound indicated cerclages, by the definition that we use here and is used most places, recognize that the majority of the people in this study, in this database, do not meet that definition. So I know that's so I would suggest either saying you're looking at a new definition, a new type, that may be used in practice, obviously is used in practice, or narrow it down to those that are prior preterm birth.
Yeah, that's true. You could say cerclage if for short cervix or something like that, because that's, you know, that's what we're using. It would be confusing because right now ultrasound indicated cerclage, like by ACOG and SMFM,
Right.
for an ultrasound is a prior preterm birth.
So pick, you're gonna probably have to do one way or the other. Either say, hey, look, we're looking at what we could find in this database, but these aren't really the definition of ultrasound indicated cerclage. Or you can say on the tail end, we're cutting out those half of the patients that didn't have a prior preterm birth because we know they really aren't meeting the definition. So you pick one way or the other, but otherwise it's gonna, you know, someone may read this and say, oh, I didn't know that's what an ultrasound indicated cerclage was. Obviously,
Yeah.
the way it's being practiced is not following guidelines, but it is what it is.
You can also provide the definition of that as like a footnote at the bottom of your table if you are tight on space.
Okay.
And then this is a minor point, but I think that they require no brand names. So Merceline
Yes.
will need to change.
Thank you.
I'm glad you reviewed this abstract, Jen. Great feedback.
Thank you. Thank you.
Another thing, I just put in the chat, but if you said ultrasound indicators are class, I'm also assuming that all cervixes were closed and no visible membranes, meaning no physical exam indicators are class.
Mhm. That's, we have that data. I think I'm just gonna rename it as cerclage for short cervix. I think that would be the easiest thing.
Okay, I mean, this is a great question.
Thank you.
Do we have enough sample size to do all these calculations?
We have, I have to go and look. Because
Okay.
depending on what was significant, what we end up excluding. Okay, thank you.
I haven't seen Sarah Ebelman yet. I haven't seen her log in. So shall we go with the next abstracts then?
Huda, Dr. Coupling. Hi, how are you?
I'm good, Miriam. How are you?
I'm okay. Just a quick question. For the BMI, do you have enough data to break it down in BMI ranges?
Oh, you mean for Jen's
Because you
abstract?
have everyone is over 30, but clearly the risk may be different for patients that have a BMI over 40. So I
Yeah,
don't know if the data would allow you to at least look at it and be able to do the analysis later based
Yeah.
on BMI ranges, maybe from 30 to 35 or even from 30 to 40 and 40 and
Yeah.
above, just to see if there's a difference.
yeah,
Because some of those patients, their risk may be related to the inflammatory process that occurs during, as we all know, because of obesity.
yeah. So, Jen, did you hear Dr.
Thank you. We
Williams'
have that.
comment?
We have that data. I can look at it and break it down by BMI range. Thank you.
I think that would be great. Thank you.
Okay. That's great. I'm not the PI on this project, so I'll make sure I communicate that with Dr. Bollig also. She's probably seeing patients.
Thanks.
Of course. The next presenter is going to be Sonia Biswas. Sonia is a third-year resident. She is going to be coming and doing a visiting residency MFM rotation with us back in October. So whoever is the MFM fellow, she will be working with you. And I met Sonia through Rebecca Hogan, who many of you know was the first author on the isolated fetal ascites paper with us like a few months ago. She did her research here when she did her rotation too. So Sonia is going to present abstracts on two reviews that we're working on actively now. One is Murrow syndrome, which was inspired by our patients who are basically, we really do not know, is this Murrow syndrome, is this preeclampsia? And the second one is on adrenal hemorrhage, again, also inspired by one of our own patients. With that said, Sonia, we can get started now.
All right, good morning, everybody. Thank you for allotting me enough time to review my 5 abstracts. Can everybody see my screen? Dr. Al-Kwatli, can you see my screen?
Yes,
okay.
We can. Yes.
Perfect. So this is our first abstract. When we were reviewing the data, we noticed that there was no consistent diagnostic criteria for Murrow syndrome, which is why this posed our first question. And we also realized that the presentation of Murrow syndrome wasn't consistent and it was very similar to preeclampsia. So we thought it would be interesting to combine these two questions, and we created this first abstract. So I can get started and read through it, and I'll continue reading until there are any questions or comments, if that's okay.
Maybe Sonia, do you prefer to read it yourself, or do you prefer Sonia to read it for you?
I can read it myself, or if there's somebody else who prefers to read it, that's fine as well, whatever works best.
The usual way we do it, Sonia, everybody looks at it and they tell you to change language. So just as a background for the fellows to teach you something very important.
Sure.
Preeclampsia and yeah?
Let us read, I think.
Read it first. Okay, great. Thanks.
What's the character count? It looks like it might be longer than 2100.
Yeah, it's definitely longer right now. We're working on cutting that down.
And I can tell you the story of why this happened. Up to yesterday, we had 2 abstracts that we combined into one. I emailed Dr. Sivari, Sonia, we reached out to him, and he answered Sonia within like a minute, we need to talk about this. This is how much interested he was with this. So we had a conference call with him last night, believe it or not. We talked for at least half an hour. he wanted us to combine the definition and the presentation together because he thinks this way it will be a much stronger abstract. And that's why really Sonia had been working very hard to do this combination along with Rebecca Hogan.
We'll enter each criteria into a table.
Yeah, we have that.
Because
Sonia, can you go down?
it's very hard to
Yes.
read. So do not, if you already have things on the table, you don't need to write them down. It's much easier to read.
Okay.
So how you need to enter those numbers into the table. Maybe a third column saying how many publications had that definition.
Oh, I like that. Yeah.
Because the text is very, very difficult to read. And I still don't understand what is the research question from the study, just to tell me that we don't know the definition.
So basically, Amanda, with my HiDocs research, when I review charts, every MFM, when they see a baby with HiDocs, we're ignorant, they say all out Murray syndrome. And in the same chart, this will be mentioned like 7-8 times. So what is really Murray syndrome, right? Murray syndrome has a different name, also called Valentine, tens of years, many years ago. Preeclampsia, the major difference is, for the fellows, remember this, preeclampsia is vasoconstriction. We think Murray syndrome is hemodilution, but how do you prove hemodilution really? So I really think all these cases that had been reported in the literature as Murray syndrome are nothing but preeclampsia. And basically we're falsely diagnosing patients with Murray syndrome when they're actually preeclamptic. So this is going to be the theme of my paper at the end. After you see this, I really think this is a very important abstract for everyone to also learn about this. We had a patient here who came to us, I think from Christiana also, they were thinking Murray syndrome, and that was a presentation done by one of the students. So yeah. Sonia, can you go back there up so that they can see the results? And yeah.
Is there a way to summarize, like all the studies had this criteria was more consistent and this other criteria was less consistent, and we proposed that the diagnosis should include A, B, C, D?
Yeah. So basically, you're right. My after speaking with Dr. Sabai yesterday, the only way we can really diagnose hemodilution is by doing hemoglobin hematocrit when you have HiDocs, and then follow that up. And this hasn't been done. Even the hemodilution that was reported in the few studies, can you imagine only 16% when it should be 100%? They didn't even define hemodilution, only one of them. So all what I'm saying is it is a field which really we don't know anything about. And I'm just challenging that disease now after this review.
I think when you put the numbers on the table, you're going to decrease the words and have enough words for the abstracts.
Yeah, I think the first sentence 2 and 3 can go into the table, and that will minimize the result section, Amanda. Do you see how the clinical presentation was so common for edema, new onset hypertension, proteinuria?
So it looks like a lot of the conclusion is about Murray syndrome versus preeclampsia, but that's the first time we're really kind of seeing that in the abstract. The objective doesn't really say anything about pre.
The thing I'm taking from this abstract is that edema was removed from preeclampsia diagnosis in 2010. But you still need to be careful attention to severe maternal edema because 67% of the cases have other pathologies. If it's not cardiac, then maybe it's Murray syndrome. Interesting.
So how shall I add the possible preeclampsia overlap in the objective? Right, I didn't know about this when we started the study.
Do you know how many of these 82 patients were suspected preeclampsia or diagnosed with preeclampsia after the fact? Or
We had HELLP syndrome in 4, and that's it.
oh,
And wait until you see the complications in the second abstract, Amanda.
somehow you have to mention that this is a differential from preeclampsia. I don't see if you included it.
Okay. Do you want me to like?
Oh,
skip
you
the
had it
conclusion?
there. Overlap.
Mhm.
Overlap in the clinical presentation of mirror syndrome and preeclampsia, but you don't have exactly how many. I mean, you can look at hypertension 43%, proteinuria 30%. So at least half of the patients had a form of preeclampsia or a suspected preeclampsia.
But this is not what the paper said. The paper said Murr syndrome.
I know.
And it's a huge number. 80 patients is a large number. Any changes for the conclusion, you think? Jen, Sarah, Neil,
What was the title again?
Keely. Oh, yeah, diagnostic criteria and clinical presentation of Murr syndrome.
And the title is good.
Mhm. But we have to make sure we're answering in the conclusion the title, basically.
You could make it more appealing if you said mirror syndrome, diagnostic criteria and clinical presentation, systematic review.
Okay.
Or mirror syndrome, systematic literature review of diagnostic criteria and clinical presentation. So
Perfect.
the
Will do.
first word in your title is mirror syndrome.
I love it. That's great. Thanks, Amanda.
Thank you.
Any changes for the conclusion? Because Sonia put this just last night after we talked to Dr. Sibai.
I think it's a well-written conclusion. It's just that the preeclampsia just kind of comes out of nowhere. I feel like it should be mentioned somewhere in the objectives or in the study design.
Okay, we can say Murr syndrome is a condition. We probably have to say then before our primary objective, we can say Murr syndrome, can be confused with preeclampsia. I'll find a better sentence. What do you think?
Yeah, or alternatively, like make it less prominent in the conclusion and just make it like a future direction as something to look at.
No, I think it's really important for me now.
Yeah, then I would add it to the objectives if that's something that was the
Yeah.
point of the study.
Yeah, so what specifically should we say? Like, shall I say a secondary objective then, or just like?
I mean, I might move the first line of the conclusion about heterogeneity between mirror syndrome and preeclampsia up to the objective so that you're kind of introducing that idea.
Mhm. Yeah,
I think that
I would say confusion between preeclampsia and Murr syndrome exists in the literature. Amanda, you're better than me on this.
I just think the conclusion is a little bit long.
No, I know we're working on it now.
I think I have to think about it. Could you send it to me?
Okay. And the objective, if we are to add a statement, shall I make secondary is like Murr syndrome versus preeclampsia? Or secondary objective to evaluate the overlap between the clinical presentation of Murr syndrome and preeclampsia, Amanda, or do you think this is too much?
I prefer a longer objective than a long conclusion.
Okay, I get it. So we'll work on the conclusion then. Okay. Okay, this is good. Anything else regarding this abstract?
Only one table?
Yes, only one table for now.
Okay, I think the table is great. You can put some of the results in the table to make it easier to read, less words, so you can, and maybe moving some of the conclusions into the objective. They sound background more than a conclusion.
Okay, we'll work on it. That's great. Thank you, everyone. Thank you. We'll go. The next one is easier. The next one is basically the postpartum complications of Murray syndrome. Maybe we have to say again, Murray syndrome postpartum complications.
So just a little bit of backstory on this. Initially, this abstract was called maternal outcomes, but we realized that most of the literature is really only discussing any of the postpartum complications. They didn't discuss a lot of the antepartum complications, which is why now we have shifted to describing this more as postpartum. So I think there are some changes we may need to make.
And for the fellows, I really wanted to read the results because it is scary, basically. Like 90% of the patients have a complication.
Do we have some sort of overall incidence of mirror syndrome?
No.
Do you have a table?
Yes.
It's again too many numbers in the results.
Okay. This table I just made a few minutes ago, and it's only showing the time to resolution of the laboratory abnormalities. So I don't have a table at this time reviewing the postpartum complications, but that's definitely something I could work on.
Yeah.
Could you go back to the abstract results?
Sure.
How many cases resolve after 7 days?
How many cases resolved after 7 days?
You said most of them 3 days, but the
Yes.
span 1 to 42. And sometimes we pay a lot of attention to the first week postpartum, and then we think, okay, you're done, goodbye.
Okay.
And then I just want to know how many are in the first week versus after the first week.
Okay. So Sonia has that in the Excel sheet, so we'll look at it and we can add it back to Roman.
Okay.
If you said that 90% of the cases had a problem, there is no need to say that 10% didn't have a problem.
Okay.
But Dr. Sibai insisted, like for some reason he said he wanted me to say 9 out of 10 patients, not even 90%. And
yeah, but I want this 90% to be emphasized, that 90% of the patients had a catastrophic events, and you need to pay a lot of attention to this syndrome. So there is no need to say that 10% did well.
Yeah. So,
I will start with saying 90% of the patients had major complications in the postpartum period as follows, and then you start describing.
Yeah. And is it okay? We can say 90. Okay, got it. I understand.
See, so just after the first sentence,
much better.
90% of the patients had a major complication. And then you start describing. And at the end, how many were resolved in the first 7 days or not? So how many you need to continue observing for a month or something like that?
Okay, thank you.
And in conclusion, you need to say at least one or more postpartum complication. I want to know how many of them are high-risk complications or catastrophic complications like ICU, look at 12%.
Heart failure.
Yeah, so they're all
yeah,
very
health.
bad complications. It's not that they have a complication, they have catastrophic ones.
Okay.
Amanda, but the PPH though, they did not define it for me. You know, was it 500, was it 1,000? But 9 out of the 21 actually required blood transfusion.
Less than 9 needs a percentage.
So you need 9 out of 20. We'll just count the 9
It's
or
like,
the 21 for the major number you're talking to me about.
You could say 51 postpartum hemorrhage with, then will be 9 out of 97 require blood transfusion. That's a big marker.
Okay.
And it's very bad to have heart failure, 10% pulmonary edema. Is the pulmonary edema the reason why they end up in heart failure?
They didn't specify.
Okay. Dysfunction, Helsingra.
Amanda, I really think most of these patients were actually preeclamptic and not Murray syndrome, and people just sat on them. You know?
Okay, I mean, this is very important information. I agree with that with you. Very important.
I'm telling you.
But I want that you emphasize in the 90%.
Yeah, exactly. I think that's why Dr. Sibai called instantly and requested a meeting.
Sounds great. Focus on those 90%, and I like the first statement of the conclusion. 90% of patients had a major complication.
Okay.
So, okay, that's great. Thank you, everyone.
Thank you.
And for the paper, you can always say that the postpartum hemorrhage was like not defined in the individual studies.
Okay.
Yeah, but I think we're gonna say that though in the paper. For the abstract, I think it's too much, Anna.
Yeah, I think just for the paper, not in the abstract.
Oh yeah, 100%.
Do you have the EVL for the postpartum hemorrhage?
We do have it for like 4 or 5 patients. Sonia, remember?
Okay, I think that's why you need to focus on the 9 patients require blood transfusions.
Exactly.
Which is consistent with what we actually have in the hospital. We don't have that many postpartum hemorrhages, but we also count for every meeting to know how many were transfused.
No, but 9 out of the denominator is very high.
No, it's 9 out of 47.
So this is close to 10%. I didn't do a calculation.
Exactly, it is too high.
It's very high. Yeah.
Like among all delivering patients, transfusions are 3%.
Exactly.
Or less.
Yeah. Great. So we'll go to the other abstracts. The other abstracts are fetal in origin. It's basically on one topic, which is great to educate all the fellows. We had a patient here. I don't know if you remember. I don't know.
I do.
Huh? You do?
I remember this case.
Yes. So the baby had like an adrenal mass, and we suspected an hemorrhage in the adrenal on the baby. And here you go. Sonia worked on a beautiful, fetal adrenal review, which is fantastic. And we look forward for your review.
I think, again, I will go for the bad news first. So of these ones, 21% persisted. Which is very high. So Of these ones, 21 adrenal masses persistent after this amount of time. Those who resolve within this period of time, percentage, and then percentage.
Okay.
Like
We'll do that.
what is immediately? A month, 6 months, a year?
Yeah, we have that information.
Do we know of endocrine problems with this
Oh,
baby?
Amanda, next slide. Hold on. Next abstract. Don't steal her thunder.
Any table of pictures with this one?
Yes. We
Oh,
have the
no, no.
plasma diag.
No, but what Dr. Oman is saying is to put an ultrasound picture, and I thought about that.
Oh, okay.
No, not the ultrasound picture, but I love the algorithm.
Oh yeah, I needed your help here. Do you think we should move everything to be lined up, everything on the left side? Because this is how I usually do it. Amelia is a third-year fellow who worked with us also on this table. She did it this way. I am used at SMFM to see everything on one side. Like, what do you think?
I think it's great.
Looks great like that?
Yeah, because I can see the titles very clearly, prenatal, foresight, postnatal. I think it's fine. If you maybe want to give a little bit more space between the letters, ultrasound, MRI, and the numbers, that'll be better. You have room.
Okay. Okay. The thing that I wanted to change is, for me, cystic is the same as anechoic, but I didn't want to feel daring to change something that the paper have mentioned. You understand me?
Yeah, correct. You have to honor the publication.
So I kept it like that, even though it seems stupid, but I cannot interchange, you know? So, yeah.
Sounds good. I like the table and I love this algorithm.
Okay, that's great.
Thank
Thank you,
you.
Dr. Oman. That's great. Sonia worked very, very hard
Yeah.
on this.
So remember, in conclusion, that we need to emphasize like 21% persistent.
Yep. And
that
then,
will help us with counseling.
And then we'll tell you what that means, because this is so important for counseling, right? So, Sonia, whenever you're ready, we can go for the second abstract.
Sure.
So, first of all, do you agree with me that we did this as a separate poster so that we don't mix the prenatal and the postnatal? I thought it's too much data and too much information.
Should we call it neonatal outcomes rather than postnatal findings?
Oh yeah, neonatal findings. I like that. Yes. That's more attractive actually too.
Yeah, and everything that says postnatal, right, neonatal.
Yes, we will.
Because we're not testing the mother anymore now. It's about the neonate.
Yes, absolutely. Yep, neonate. Yes, the neonate is the patient.
So aside from having a bad imaging, any other I don't see the implications. I mean, I don't care if I have a cyst as far as it doesn't bother with my life.
So, Sonia, you want to answer that?
Sorry, could you repeat the question one more time?
I want to know the health implications for the neonate I may not care about having an imaging problem, but I want to know if there is an endocrine problem. I can see a neuroblastoma, which is not good.
Yeah, so
Right,
this
so-
is good. Yeah.
So 14 of the cases reported evaluation for adrenal insufficiency,
Excellent.
and all of those were negative. So that was right here.
So in general, they have a good life,
Yes, exactly.
despite the fact that they have a mass. That's good. I can feel better now telling a mother, you may see this imaging for a long time, but babies did well.
Exactly,
So I
and
want
this
that
is,
conclusion.
yeah, very important information, very, very important information. Like, you know, adrenal insufficiency workup to be performed, and very important for the fellows neuroblastomas too. You know, you have to be suspicious when you see an adrenal mass for neuroblastomas.
And again, the conclusion is too long. I have to read it again. I wonder you summarize a little bit the conclusion saying that prenatal finding of adrenal mass it will continue abnormal imaging in neonates in this amount, and it will require studies for this and that, but in general, good outcome.
Okay.
Studies to a lot of information in the conclusion that is already in results.
Okay, thank you.
Or despite the fact that the neonates continue having abnormal imaging, there was no adrenal insufficiency or
abnormal venal Mandelic or neuroblastoma workup.
Or neuroblastoma was negative.
So you think I should put that in the conclusion?
Yes, so I want that you give us good news.
Okay, very good. Okay.
Because now I'm feeling much better. Different than the mirror syndrome that I'm now more worried. And now I'm at ease thinking that, Mom, don't worry, the mass will continue being there, but most babies did well.
Okay.
Okay, thank you.
Okay. Any other comments from the fellows regarding this abstract?
No other comments. I agree with Dr. Roman to like make the conclusion smaller. Shorter.
Okay.
Thank you.
Great. We did add the neonatal presentation, the neonatal physical exam. Do you think we should include that in the results?
Yeah, it's fine. The physical exam was what, normal?
A palpable mass or abdominal distension in a third.
Okay.
And normal in 50%. So we're just teaching them that you need to feel that belly. You know what I mean?
Okay.
Even if it's an adrenal hemorrhage. Okay.
Yeah, examine your patients. Not everything is an imaging.
Okay, great. Okay, and then I think, Sonia, you have only one more?
Yes.
Okay. And this
Who
is
got the surgical
yeah.
Who got the surgical intervention? The neonate?
Yes.
Neonatal cervical interventions.
Okay. Got it, thanks. So who from the fellows is here? Anna, Keely, Jen, if you can give us feedback regarding the results.
Why this one needs to be a different abstract from the last one?
You're being like Dr. Sibai now, Dr. Oman.
I am glad to hear I'm getting the level of a professor now. Yeah, because it looks okay. You guys just gave me a good news and now you're giving me bad news again. But 20% of the babies will need surgery.
Yeah, so around 25% will require surgery. And can you go to the table, Sonia?
Yes.
Yeah, because the only thing is that the other abstract was about neonatal outcomes. So then it would be like interesting to know these.
Yeah, but we said, remember though, we said 21% persisted, correct?
Yeah.
So 21%, and there was 1 or 2 more cases that had other clinical signs, so they took them for surgery, and this is the indication for surgery.
Okay. Should you include that the surgical requires surgery in the previous abstract?
Do you think?
I mean, you can mention it.
We
This
didn't
is more
report on management for these babies, right? We had 20%. I didn't, I never want to commit fraud by reporting the same thing into abstracts in case both of them got accepted, but you know, probably only
no,
one
but
of these.
I think you can add surgical management 25%. And now this abstract talks about in detail of those surgical findings.
Okay, fine.
So you still have 2 abstracts, but then you don't left out that the babies may need surgery. This is a big
Then we're gonna
outcome to
add
tell
it.
patients.
We will add it. Okay, and you
Like,
don't think we're committing fraud?
No, I don't think so. It's just a surgical intervention, 25%.
Okay.
If you want to know more, go to the next abstract.
Okay, I like it. Okay.
Okay, now then I'm telling that if I diagnose the next patient with adrenal hemorrhage, I'm going to tell her that it will be imaging, that 25% of the babies require surgery, but most of the results were positive, cancer or insufficiency.
No, what were the results, Sonia? Sonia actually put the pathology reports. Sonia put the pathology reports for all cases, and there was only 1 case that had an in situ neuroblastoma.
Right. Okay. And surgery was only performed in the cases where they suspected neuroblastoma. So they only did the surgery to rule out neuroblastoma.
For how long did they follow these babies? 1 year, 2 years, 5 years?
I think that it varied. Some reported how long they followed and some did not.
And so just report these babies were followed from 0 to 10 years.
Okay. Okay, Amanda, I didn't consider that. So that's a great comment. Thank you.
I think these are wonderful results, are going to change the way I consult patients next time I see this.
Yeah, I think they would. Okay. Any other changes?
No, I think just be sure your wording is correct. This one look great. Thank you, Dr. Akuadli, for your mentorship. You're bringing very, very interesting topics that will change practice.
Oh, thanks, Dr. Owen. Inspired all by patients. Thanks for your feedback and for your excitement about my work too. Okay. Fellows, do you have any questions regarding any of the abstracts or clinical or anything else?
And good job, Sonia, 4 abstracts.
Thank you so much. I appreciate
Amazing
your
job.
time. Thank you.
We're gonna see her next. We're gonna see her in October. Sorry, her camera was not working today where she is at the hospital. So thank you, Sonia. Take care.
Good job,
Thank you
Sonia.
so much, everybody. Thank you. Have a good day.
Do we have any other abstracts? Anybody have abstracts to present?
Yeah, I have one if we have some time.
Oh yeah, we do. The only thing is, I don't know if other fellows though have time to give feedback.
Yeah,
Um,
we're
the Keely is
sending them
on,
between each other.
what?
So we're sending them between each other too. So
Yeah. Okay, so the only fellow I see is Jen, Keely. Yeah. Okay, and Anna. Perfect. Yes.
and then we just have one table.
Did you correct for those confounders that had differences?
Yeah, we adjusted the odds ratios based off of that.
So, okay. The groups look very different.
They're really different for the EFW, less than or more than 90%. They only differed for the AC on maternal age, but we adjusted for all of those and potential confounders in the when we did the logistic regression.
Could you go back to results? I want to see. I mean, they didn't have gestational diabetes, but did you look at outcome of birth weight and complications?
We have a separate abstract looking at the association with LGA at delivery. We don't have any fetal complication data.
Because the main didn't have a GDM, but they may have complications at delivery.
Yeah. So we looked at LGA and shoulder dystocia in a different abstract. I don't have like NICU additions or anything like that.
Are you presenting the one with the neonatal outcomes? Or are you showing it today?
I'm going to do that one tomorrow. I just have to clean that one up a little bit.
I just wonder if we have two abstracts, one with EFW and another one with abdominal circumference.
So that's how I had done it originally. And then talking to Dr. Alquali and Dr. McLaren, we thought it might be better to separate it like kind of this way. But I'm open to doing either way, depending on what people think.
Could you show me the table again?
Yeah.
The table is wide. Make two tables. Okay. One for EFW and another one for AC.
Okay.
Perfect. I was looking for feedback for the table too.
Yeah, it will be too wide, difficult to read, yes, when it gets published.
Yep.
Gotcha.
Agreed. If we have time,
do you have a gestational age at the time of diagnosis, or does it matter?
I don't have that.
You mean at the time of ultrasound?
No, at the time of GDM diagnosis.
Oh, GDM, no.
We don't have that data. Oh, we could get it, but we don't have it for this subject.
I mean, that's fine. That's fine.
Yeah.
Usually at 28 weeks.
Yeah.
Amanda, do you prefer that we show you the LGA abstract too? Oh, let's wait.
Yeah, I would love to see it.
Yeah.
I just wonder what is the GDM incidence on the general population? It sounds, I don't know if it's too high, 12, 11%.
Yeah, I pull up the LGA one.
Okay. I mean, it's great. I mean, you have a great number, 2,900, 3,000. Good job. Good job, Neil. I always wonder when I read in these anatomies.
I know. And then I get worried. The baby is 99%. You know, what am I going to do, right?
Should I scare the patient?
What? I don't disclose it to the patient so far, but now I feel more strongly about it, right?
Yeah, I sometimes tell them, but say, don't worry.
Here's the
Another question, Neil, did we do growth on those babies? Most of them may have an indication for another reason, but did we do growth ultrasound at 32 weeks?
We have not done that, Amanda.
yeah.
And I plan to get hopefully a medical student to help us with that.
Okay.
So we have the third trimester ultrasound data. We just haven't abstracted it yet.
I'm sorry, Neil, what you haven't abstracted yet?
The third trimester ultrasound data.
Oh yeah, we haven't, right?
No, we haven't.
Yeah.
This is a big difference, more than a pound, almost a pound.
Mhm.
Can I ask a question?
Mhm.
Yeah, there again, are you able to break down by BMI ranges? Because I wonder if.
Yep.
Yeah.
So we have an entire abstract on BMI, Dr. Sorrentino. You're gonna be so happy when you see it.
Thanks, Dr. Al-Quatli. You made my day. I can't wait to see it.
Inspired by you.
I love this abstract, Neil. Show me the table.
Mhm.
Again,
You're
just
lucky
break it
if
in
Dr.
two.
Omen loves something that's amazing, okay? Her standards are very high.
Good job, Neil. Just make it in two, one on top of the other one.
Mhm. Okay. Yeah, I can show the BMI one.
There again, Dr. Al-Quatli, if we're able to break down, I'm curious, if we're able to break down by BMI ranges, I wonder if we would be able to even have enough for separate studies based on our findings.
Here's the BMI one.
You know, if we were able to differentiate based on BMI ranges. Because those could be, you know, separate papers on their own, because there is a lot of excitement and a lot of curiosity.
What about BMI 30 to 35 and 35 to 40?
Like even like 25 to 30, under 24, under 25, 25 to 30,
Yeah,
30
so
to 35.
we broke it down like normal BMI versus obese, class 1 versus class 3, I believe. Which I was trying to make it as like few categories as possible, but we certainly could break it up more. Yeah.
And then the other question, are you able to look at gestational weight gain during pregnancy? Because there is a correlation with excessive gestational weight gain that may also correlate.
Yeah, but Miriam, I totally, yeah, but that would be a separate thesis with a separate project. Certainly total weight gain is associated with increased birth weight. My objective here is looking at your 20-week ultrasound and how much information can I gain? If I have a big size baby, am I gonna worry about a big size baby at birth? You know what I mean?
Yeah. Also that is difficult to extract from. Not everybody enters that data.
Yeah.
Thank you for that.
Absolutely.
But this paper doesn't have the baby outcome.
Yeah, we never collected. You want us to collect neonatal outcomes, Amanda?
Yeah, how many were large at birth?
Oh, I got it. So we did discuss this, me and Neil last night. And that's why we didn't know if we should include it or no here.
Yeah, I think so. Just to know the implications by BMI. maybe I'm focusing more on certain BMI than another one when I consult the anatomy. Should I, well, we already doing growth 28, 32, and 36 for them. Excellent job, Nip.
Thank you.
That's great.
We're done?
I think we're done. Is there anyone who wants to present? We do have an entire session tomorrow.
Okay.
Yeah. Okay. That's good. Dr. Bollig was gonna present for Sarah Ebbelman, but she's busy. So I think we're finished.
Okay, wonderful. Thank you.
Take care, guys. Bye-bye. Thanks.